Absolutely not a
Okay,
problem whatsoever.
thank you. I'll turn it over to you.
Okay. Well, thanks for having me, everybody. I'm excited to be here before you to discuss the clinical contact center modernization efforts that are occurring nationally, as well as the efforts here in VISN 2. And you're just the people I want to speak to in your outreach so we can get the word out about the clinical contact center to get it utilized as much as possible. So to start, for those of you that don't know me, my name is Jeff Wilkinson. My position is Division Two Business Operations Director, which includes being the Clinical Contact Center Director that we'll be discussing here today. I also have oversight over the Vision 2 Clinical Resource Hub as of July 2022, and I also supervise the Business Implementation Manager and all that that particular position entails. As for my education, I have a BS in accounting and my Juris Doctorate or my law degree. I've been with the VA or the federal government for 17 years, 13 of which has been with the VA, primarily in the Business 2 Network office, holding various roles and responsibilities. The last being that business implementation manager position that I previously mentioned. There we go. Um, and prior to joining the VA, I served in the United States Marine Corps. That's where that additional 4 years comes from, federal service. And I joined the private sector and had a few managerial accounting positions prior to coming to the VA while pursuing my education. But enough about me. So here's the agenda for today's meeting, starting with how we got where we are, the services that are being provided or expanded upon, the IT systems that we are utilizing, the current state, and then ending up with open discussion and answer any questions we might have. I'm going to try moving through the slides quickly so we do have some time for open discussion. So to start, you may already be a little bit confused as you may have heard the terms clinical contact center, as you also have heard the term VA Health Connect or VA Health Connect 365. And the symbol was just depicted on the previous two slides. The term clinical contact center or CCCs was the name of what was used to describe the services being offered, which we'll get into here in the next slide. However, since then, branding of these clinical contact centers has taken place, and it was decided to use VA Health Connect 365 as the name of the VA's entire network of clinical contact centers across the country, with the tagline of the right care right now, and the expectation of providing first contact resolution to the fullest extent possible. However, since the initial branding, the 365 portion of that has been dropped, and it is only now referred to as VA Health Connect. The term clinical contact center still may be used to describe the modernization efforts as a whole, and I do, but really refers to the specific VISNs, clinical contact centers. But I wanted to bring this up to you as you may see VA Health Connect and clinical contact centers used interchangeably, material from VACO as well as the VISN. Now let's discuss how and why the clinical contact center modernization efforts was stood up. So historically, every VAMC or healthcare system and VISN across the enterprise has developed and led their own locally driven call center operations with differing services, methods of delivery, staffing, and standard operating procedures. Moreover, access to the service has been limited to business hours, meaning gaps in service coverage or reliance on weekend, holiday, evening, and night centers scattered across the country. System technology and software infrastructure was also outdated and did not support workload sharing and contingency planning. And then COVID hit, which became the key driver behind creating the clinical contact centers and the volume of virtual care that was taking place across the country. And this further highlighted the need for standardization and centralized data by VACO. At the end of May 2020, the VHA Governance Board approved centralized clinical contact centers at the VISN level with four core services that we'll get into here momentarily and self-funded by each VISN. At the same time, VA OINT committed funding to furnish upgrading of the telephone infrastructure at every VAMC by 2022 and install new supporting software. There was also a new change of the programmatic oversight and accountability for the clinical contact centers, as that was shifted from the Office of Veterans Access to Care, or OVAC, which is now referred to as the IVC, or Integrated Veterans Care. And that, well, the previous reporting was the Office of Nursing Service. This led to the Clinical Contact Center modernization efforts, or VA Health Connect. So the future state of where it was and the current state of where we are now, since we are fully operational, includes four mandated standardized services that all VISNs across the country needed to operationalize in some form or fashion. And they include clinical triage by nurses to discuss the symptoms, concerns, and receive recommendations for the best course of action. This could include going to the VA or community ER, making an appointment with our own CCC providers that I'll mention here shortly, or scheduling an appointment with their own primary care provider, or even at-home education so they can stay at home and not receive any further care. This service was already being provided out of our JJP VAMC nurse advice line, which was already serving most of our VISN during win hours, except a few facilities. This was also the first clinical triage center in the country, but back in January 2021, we realigned those staff to the VISN. The next service was to provide virtual health clinic visits with dedicated clinical contact center providers and to provide that care via phone, video, or down the road, perhaps chat, that are referred from a nurse triage department or our clinical triage department to address veteran episodic or urgent care needs in detail and obtain that first contact resolution as much as possible. In other words, we were tasked with standing up a tele-urgent care center. Now, JJP, that a nurse advice line, had 5 nurse practitioners that were providing this service, but only to the JJP veterans, and we realigned those staff to the VISN at the same time. We also have to provide pharmacy support services. They include the ability to refill, renew medication, medication reconciliation, and speak with pharmacists about medication-related concerns. This service was previously provided under contract by Member Services in their pharmacy call center. In order to comply with VACO's new requirements, Member Services was offered to expand the services as well as the hours of operation, but it came with a hefty price tag. Therefore, we wrote an EDM to move away from them and stand up our own at nearly half the cost, while at the same time a more extensive program and, of course, more control. The fourth service, as you can see, is the scheduling and administrative service to help veterans make, reschedule, and cancel primary care appointments only. And I stress primary care because lines can be pointed and communication can be misconstrued. I would just want to point out at this point in time, we only handle primary care appointments, and we can schedule at any medical center within our VISN or make an appointment with our own CCC providers in the tele-urgent care, as well as answer general inquiries and receive additional information about VA services. Down the road, we'll see if it expands to mental health services and specialty care scheduling. But it sounds like VACO has decided that we need a new scheduling package before we can think of expanding further, which they are working on. A little history as this department is set up differently. Upon moving forward with standing up this department, VISN and facility leadership met, and facility leadership wanted to retain their primary care scheduling call centers during business hours. So the scheduling calls for primary care that go to the facility phone tree are going to the facility team during business hours and then routed to our VISN CCC scheduling team during win hours. If calls come through the 1-800 number for scheduling, we of course can take care of that veteran. These services are offered 24 hours a day, 7 days a week to include holidays, with the caveat that the providers are available 6 a.m. to 11 p.m. and the pharmacists during that same time period. But the pharmacy technicians are available 24/7 and the RNs can cover if needed. I mentioned first contact resolution on this slide and in the previous slides, and the intent is just for that. For the first contact resolution, which aims to connect the veterans with the services they are requesting in a seamless and timely process. And that's what we're trying to do. And you'll hear about our performance metrics and the average speed of answer goal at which we're trying to answer all of our calls. But how are we going to provide those services? Well, here are the major system upgrades that have or will be coming down from national to assist in providing the services we just covered. I like the analogy that the previous OVAC, or I guess now the IVC director, Dr. Kirsch, usually stated in her presentations. And in her presentation, you say, you know, back in the day, my computer was a big block on my desk. And now, and she'd hand up her phone, he said, this can do even more. And that's what we're doing with our technology today, and especially our telephone system and call centers in the technology arena, and that we're making a giant leap into the 21st century from where we are. Starting with that telephone system. In our VISN, there were previously 4 separate companies or carriers, which is being reduced to 1, Cisco, and completed from my viewpoint, although there's still changes that need to be made throughout our hospitals, but as it pertains to the clinical contact center, we're completed. There was a tremendous amount of issues prior to that, as we had the oldest phone system in the country. Very excited that this got completed. Next, Cisco Jabber, and that's just a phone on a computer device, the phone that's on your desk. And the Finesse allows for the management of those calls and queues, both of which are operational in the VISN 2 CCC, as well as in your facility primary care scheduling call centers. Calabrio is our quality management system that allows for call recording and where we where we're told we would have screen scrape or capturing, as well as artificial intelligence that will perform voice analytics to analyze and transcribe recordings for quality purposes. I don't know if that's going to come to fruition. We're still excited to use this product and it seems to work quite well overall. And it sounds like we're going to get a workforce management tool, but all the other bells and whistles, the artificial intelligence, it doesn't seem like it's going to happen at this point. We're very even more excited when we receive the full package of the CRM, or the customer relationship management system, which is going to be the product where we document the interactions with the veterans and provides our staff with a single sign-on to all of our facilities. You may be familiar with CommCare CRM, which is also being used in our facility community care departments, or at least should be. And this is Connect CRM for our CCCs. This should effectively streamline all of our processes, bringing 16 different systems into one, along with provide us much better reporting capabilities in the future. Excuse me. We'll be going live with our clinical triage department on this system, hopefully next week, March 1st, I believe it is. And the rest of our departments will be going on a few months down the road throughout the remainder of the calendar year. But the expectation is that we'll receive an MVP, or a minimum viable product, and it's just going to be that minimum to start with. And as we will not have all the bells and whistles at the beginning, and it'll be built over time. That there has been issues so far, and I would not be surprised if the other departments' CRM products are delayed a bit. I'm not going to talk about Cerner, as VISN 2 is nowhere near the implementation of that electronic health record system, and hopefully that'll be a few years down the road. I added this slide to help explain the information and one of the opportunities for improvement by using this technology, even though it's data pertaining to performance. First, I wanted to show the information from the telephone call center dashboard on the VSSC that required manual reporting by each facility in the past. And not to pick on Western New York, but it is for example purposes. And unfortunately, you can see here that Western New York had not been reporting in FY21. And in FY20, overall, there was only 72,000 scheduling calls with an average speed of answer of 51 seconds and an abandonment rate of 5.9%. However, in FY19, there was 160,000 calls, so over double the calls with an abandonment rate of 6.4% and just slightly over the 30-second speed of answer goal at 31 seconds. The reason for the difference is, as you can see here, is that not all the months were being reported in FY20, leading to the disparity in the call volume from FY19 to FY20. So again, a reporting issue similar to FY21. You can also see the monthly variation in the speed of answer and the abandonment rate from month to month. I provided these last two slides not to point out deficiencies, but for two reasons. First, it is no longer necessary for facilities to self-report each month, as it's captured under centralized and standardized Cisco telephone system, which, if you recall, was one of the main purposes for the modernization efforts by VACO. Secondly, being on the centralized Cisco system, this technology has the capability to allow the VISN CCC agents, or any facility agents, to be skilled to assist each other by skilling them to have that ability to schedule for that facility, such in times of high call volume or staffing losses, whatever the case may be. But of course, this would be dependent on the CCC and other facility staffing resources, call volume. And at this point in time, our CCC is not in a position to assist our facilities at this time, but we are working on that through recruiting. So where are we, and where are we going besides the new phone systems? We have our single toll-free phone number as we continue to use the JJP Nurse Advice Line 1-800 number that I mentioned earlier, since it was servicing most of our facilities already and many veterans were familiar with it. However, I want to point out that our veterans can get to the CCC through every hospital phone system. When you press 1 on the IVR, you get our pharmacy department. When you press 3 on your IVR, you get our clinical triage department. When you press option 2 outside of those business hours, you get our scheduling department. So, and we prefer that they get routed through our facilities, as it's easier for call tracking, and it's probably easier for veterans where they don't have to remember an additional number as well. Our committees and IQTs have been established, along with an internal communication plan that has been rolled out to each facility a few months ago, and an external communication plan that includes flyers, business cards, magnets that have been distributed to each facility. And we'll have more to come on this here later in the presentation. We have our CCC leadership team on board and continue to recruit, interview, and onboard staff as we hope to get to as close as possible to being fully staffed as we can. Currently, I think we're around 90% onboarded and or selected. The IT infrastructure will be implemented at various stages, as we just covered, but we have other systems that we'll mention here in a bit. We have finalized our quality oversight process and activities that have and we have our quality staff onboarded for each department or identified. And I say identified as we don't have a quality person in our virtual clinic department. We have just a lead, if you will, an identified SME for that particular department. We also went live with VISN 1 on January 5th, 2022, providing clinical triage and scheduling and administrative services during WIN hours. Last but not least is the go live implementation plan for each facility within our VISN 2. You can see through the rollout of each service, it was a tiered rollout approach, and we finished the final stretch and completed the I can't say it. We finished it in February of 2022. Part of this process was looking at the facility's phone trees and ensuring they were set up properly. And we still have some work in that arena, but otherwise, overall, I'm extremely happy with the way the implementation came to life. Added this slide from our previous facility leadership meetings. And if you don't know what WIFM stands for, it's what's in it for me. And it's catchy and it targets our audience's attention to buy-in into what is being presented. And we really are just an extension of the facilities that we're servicing and not replacing them by any means, but effectively adding to all of our facilities the ability to offer these services on a 24/7 basis. Even the way we set up our providers are logging into our facilities systems and encountering within there so that they retain the full workload credit of our veterans. The clinical triage services standardized across all sites with NPs for tele-urgent care to take care of our veterans immediately instead of going to a brick and mortar, either VA or community, as much as possible if the issue is applicable for telehealth services. Our pharmacy services are now offered 24/7, brought in-house under our control, and again, a much better product with our pharmacists and doing it at half the cost. We expanded the primary care scheduling administrative services for all of our veterans so they can call and schedule an appointment or cancel an appointment at night or on the weekend and don't have to wait for the next business day. This should allow for our facility PAC teams to focus on the veterans in clinic that they have scheduled and reduce the number of same-day visits needed that take place in our PAC teams, as well as those block times for those same-day appointments, freeing up appointments to be scheduled for our veterans and providing better access for care. Being a veteran, I've been on the receiving end when ill, and you call our CVOCs, and the message is a nurse would get back within 24 hours prior to the CCC being stood up. And now the PAC nurses won't have to make those phone calls back. The veterans won't have to wait, as the expectation is our nurses will answer within 2 minutes. In addition, this reduces our MSA's call volume during business hours and voicemails that need to be returned as those calls are being handled during those 1 hours. We should also see improved performance metrics from what was previously in place, especially as we saw a few slides ago, as it's all automated and not based upon manual reporting, but also an increase in veteran satisfaction with not having to have a copay for any of these services. If applicable, there may be some copays for medication. But the added benefit of not having to wait in the community ERs or urgent cares and the ability to sit at home and be triaged accordingly, it's a tremendous additional service for our veterans. There are also the other benefits we mentioned before, such as the agility to support in daily operations in the future and contingency planning and disaster and emergency management. I don't know, such as like a global pandemic. Hopefully we don't have another, but you never know. Also regarding WIFM, as previously mentioned, the long wait time in the community when going to the community ERs or urgent cares. And one of our main goals is to reduce the volume of care occurring in the community emergency rooms along with the associated costs and try to have the complexity level that goes to those community ERs be of the appropriate complexity level. Here on the left-hand side, we have the ER payments from OCC IDA, and I didn't update these slides with the FY22 data, and I apologize. And this data is not completely accurate. If you're familiar with our community care expenditure reporting systems, there's some difficulty in terms of that. But it's still showing $173.6 million being spent by our VISN and ER in FY22, FY21. On the right-hand side is the VISN urgent care payments in FY21, which we are one of the smallest in the country in terms of community urgent care utilization and payments. But that is still another $1.6 million that has been expended in that the CCC can try and reduce. As I've been stating at all of our facility leadership presentations, with such a large apple to bite from, I know we can try to reduce the amount of ER care occurring in the community, especially when looking at the primary diagnosis for why veterans are going to the community. And because of this, and you can say, Jeff, there can't be much more. And I say, yes, there is. So as of March of 2022, we added emergency trained physicians and stood up a tele-emergency care department. Therefore, based on the disposition from our clinical triage department, and if applicable for telehealth, we have providers that can see patients that should be seen now or 0 to 2 hours or are refusing to go to the community or VA EDs. So it's a tremendous benefit. And this, of the calls we're seeing, this actually allows us to see about 80% of our call volume, where prior to that we were able to see about 60% and weren't able to take care of those dispositions of a now emergency need. Moving on to the measures of performance, and these are the performance metrics that we are monitoring. First, starting with the average speed of answer, which the goal of that, as I mentioned previously, was 30 seconds. So we want to answer the calls within 30 seconds. The only outlier to that is our clinical triage department, which their average speed of answer is 2 minutes. I'm not a big fan of that, and we are looking to move that forward to be in standardization with the rest of our departments. Although not shown here, the service level goal is 80% or greater, and service level comprises of the percentage of calls that had the average speed of answer goal met, which again, the average speed of goal is 30 seconds. So in other words, in order to meet the goal, 80% of the calls presented would have to be answered within 30 seconds. Calls answered and total customer contacts, which includes transfers. We track both internal and external transfers. The abandonment rate, the goal is to have equal to or less than 5% abandonment rate. We also track our average handle time. We currently do not track our first call resolution or CRM categorization. As I mentioned, we're not on CRM at this point in time, but when we are, I'm sure we will track that. There's some differences of how to track first call resolution and how it will be tracked, and I haven't heard much about that from a national standpoint at this point in time. Other systems that I mentioned that we are utilizing, we do utilize vSignals and implemented that for review of veteran satisfaction for the services that we're providing and perform service recovery for those negative responses. But in actuality, we are receiving quite positive feedback in terms of vSignals. We also utilize Calabrio for our quality management system and patient safety reviews. So let's look at the numbers and how we're doing. And there's a lot of red here, but there are growing pains and reasons why they are the way they are. But we're not going to get into the details of that here for this call. But you can see we had over 115,000 calls come to our CCC in the month of January, which is an increase of 4,500 calls from the previous month. And we handled 86.4% of those calls handled, which is 2% more than last month, and almost nearly handling 100,000 calls. There was a 9% increase in the service level to 59%, which again, the goal is 80%, and that goal is actually optimized. We don't want to hit 100%. We want to be around that 80-85% level, as that's optimizing our resources and our staffing. When you get into that 100%, 95%, that's when you're overstaffed in your particular departments. Looking at our average speed of answer, it was at 1 minute and 42 seconds. So over triple the goal, but it's still not too bad. And the reason I say that is you can see the improvement from 1 month to the next. So that's one. Secondly, there was actually 2 holidays in the month of January, which the holidays kills our scheduling and administrative department and really impacts our performance as a whole. And we're making changes for that for upcoming months. See, I'm almost running out of time here. The abandonment rate was at 13.4%, which is high, especially with a goal of 5%. But again, the two holiday impact, again, really hurts. But you see we had a 1.1% improvement and despite that second holiday. And there's also a 43.44% abandoned prior to meeting that service level. And what that means is 44% of that 13.4% that abandoned actually hung up before 30 seconds and effectively not giving our agents the opportunity to answer the call. Here's the data in the block form broken down by department because I wanted you to see the volume by department. Pharmacy is our largest department in terms of call volume at nearly 50 to 60% per month, and our overall CCC performance is driven by that particular department. But the other departments have significant impact, as I'm mentioning the holidays alone, in our scheduling and admin department, which our scheduling and admin and clinical triage department both account equally per month for the remaining portions. Again, you can see the impact of the two holidays on their scheduling department performance metrics. But however, the gleaming light is in that bottom right-hand corner, which is the last week of January. We're hitting the performance metrics as a CCC overall. Here is our org chart in order to handle all those call volumes, which have been updated fairly recently and approved by our VISN resource board. Not going to go into much detail, but the point showing here is that we're planning on needing 221 staff, of which we are around 85% onboarded, not the 79% shown here, and about 90% once you incorporate our selected as well that we're working to get on board. We continue to press forward on staffing in order to be fully staffed and hopefully to see the performance improve that we saw on that last slide on that bottom right corner, and expecting a great February. So lastly, what can you do for me? Get the word out, and my goal again is to reduce the care going to the community. Give us that bite of the apple and inform veterans of the new services or really the expanded services being offered to them. By having the clinical triage department and tele-urgent care and tele-emergency care department, we have been effectively keeping 80 to 85% of our veterans from needing to go to the community ED or UCs. This does, however, include our nurses and physicians sending our veterans to our own VA EDs and urgent cares, but the bulk of which we've been able to address in some form or fashion. But this is great news as we'll be able to drive the care to our own VA hospitals by expanding it out in the community. Of course, this goes without saying, if our veterans are having a heart attack, they cut off their arm, or whatever the case, they need to go to an emergency room, and there's nothing we'd be able to handle virtually. So shown here are new flyers and business cards that will be coming to all of our hospitals for replacing the older versions that hopefully you have seen that are displayed throughout your hospital in the primary care areas, EDs, UCs, pharmacies, and hopefully being promoted. I can tell you that our Western New York and our New Jersey healthcare systems, you can easily see how much they promote our CCC, and it can be seen in the utilization by their veterans. And one last thing, and yes, there is more. So on both our new brochures as well as our business cards, you can see VA Health Chat, where veterans can access our CCC pharmacy department, clinical triage department, and scheduling department via chat, either on their computers or from the app where they can download it on any one of their electronic devices. We went live with this feature at the end of July. It's really just starting. It's trickling up on utilization by our veterans, but another great avenue for our veterans to get in contact with us. And with that, that is the overview I had prepared for the CCC today, and I'll open it up for any questions.
Hey, Mr. Wilkinson, it's Glenn Gilbert in Albany. Thanks for your presentation. Thanks for the CCC. I oversee the patient advocates here and veterans experience here in Albany, and we would love to do a lot of what you're already doing, particularly along the lines of use of technology. The system is antiquated in many respects, and so getting a better technology with our telephony would be great. I don't know if you have a point of contact or a reference to work with what's available here. If you have that or could send me something, would appreciate that just as we try to upgrade. Call lots of the same metrics that you're looking at in terms of drop rate and how fast we can answer calls, how long we're on the calls, those kinds of things. The second thing is I wanted to mention is you're going to go with CRM. That's a challenge for me. We have to use the PATSAR system, but a lot of community care stuff is going to go through CRM. Reportedly, CO didn't bother to do the paperwork and look at PATSAR and CRM, so it may involve learning two systems here. But thanks for sharing that. Didn't know that, and was debating whether I really needed to become proficient in CRM. I'm guessing that down the road it will be a benefit to do so. I want to tell you that we refer patients all the time to CCC. Thank you for being there. They love it. We get a lot of good feedback from patients who really appreciate that. And finally, do you know is the local call center in the facility under your supervision, or is that separate?
So I'll start with the first last, or the last first. So the local facility call centers are not under my supervision. I'm gonna say that right now. Not under my supervision currently. I've been called out as being not in compliance with the new CCC directive because they're not under my supervision, as the VHA directive requires the clinical contact centers to have dedicated VISN staff. However, back in April of 2021, I presented the VACO's intent, and our medical center directors were not in appreciation with that viewpoint and wanted to maintain control. And VACO approved that model, if you will. However, it seems they are taking that under question at this point in time. Are going to be speaking with the network directors on that matter. So currently, the facility primary care scheduling call centers report to the medical center directors, medical centers, and currently do. However, their performance and their data report underneath my data and are included in my data. So when national reports on the command centers, the Albany, every single facility scheduling call centers are coming up and reported and included in my scheduling department and rolling up into my CCC overall performance as well.
Okay.
PATSR and CRM. Great question. I've heard the saying that they're not incorporating the two. One thing we're doing here at the VISN, trying to get a VISN level patient advocate that can manage the PATSR, provide oversight also for our facilities. But that's also going to be a communication flow for us as well, for veteran service recovery, veteran feedback, and the like.
Okay.
Hopefully down the road that'll be incorporated as well.
Okay.
And then lastly, UCIS, Uniform Communication. I can't think of what the IS stands for. Mark Allen is the director of that. And actually Tim Stanton, and I can drop his name in the chat here. He is our VISN point of contact, and he would know where we are from a VISN standpoint of rolling out Cisco to the rest of our hospitals if it hasn't been rolled out to all of them at this point in time. Because they were initially just standing up the new telephone system to get the CCCs rolled out, and then going to circle back to finish out the rest of the hospitals. But where they are on that, I'm not quite certain.
Okay.
Just dropped
Mr.
his name.
Wilkinson, I
Great.
have
Thank you.
two
You're welcome.
quick
Thank you.
questions. I just want to make one. I want to make sure I understood you earlier. So it sounds like I'm thinking like a hypothetical example. I'm a veteran. I go hiking and I brush up against some stuff, and I think it's poison ivy or poison oak. Instead of going to the ED, I can call the call center, and they can connect me to the on-call ED physician who can maybe see me through telehealth in lieu of me spending 12 hours at Albany Med to get a appointment.
Absolutely. So
Okay.
you can either call our 1-800 number, or you can call your facility, press option 3 for a symptom to speak with a nurse. You'll go to our CCC clinical triage department. Our nurse will triage you. They'll use a decision support tool, currently TXCC web based, moving to TXCC when we're on CRM. That's irrelevant, but they'll triage you, and based upon what comes out of that decision support tool, the rash, I don't think it would be a true emergency, but if it was an emergency, we have our emergency trained physicians in our tele ED department. If it's a urgent disposition or needs to be seen between 2 and 24 hours, we'll try to get you scheduled with our nurse practitioners in our tele urgent care department. If it's something that can't be handled virtually, we don't deal with anything with genitalia or something that might be heart related or something. We'd send you to the VA EDs, and of course, if too far and not medically appropriate, we'd send you to the community. So, and that's what I mean. Just give us the first bite of the apple, and we'll triage you to get you to the appropriate level of care that's necessary.
Perfect. And I wanted to thank you. The other part was just a comment. I wanted to thank you for sharing that health chat, because I just downloaded it while you were talking with Glenn, and it looks really helpful.
Oh, it's a game changer. So instead of having to sit on the phone with somebody, and it's just like anything else, Walgreens, would you like to chat with somebody? Uh, our farm technicians are manning it. Our advanced MSAs are manning the scheduling department. We have our nurses for our nursing department. Now, triaging via chat has its own difficulties, right? So most of those calls are transitioned to a phone, just due to the amount of questions that the nurses have to ask to triage a veteran based upon their symptoms.
Does
However,
anyone
that
else
is
have,
the bulk of those chats that we do
yeah.
receive at this point.
Does anyone else in the group have any questions for Mr. Wilkinson? All right. Well, I want to thank you for your time.
Yeah, but thank you for having me, and we will be getting out material to all of our facilities. If any of you would like individual packets for distribution, please let me know. Please don't hesitate to reach out, and we'll get it out. Trying to promote this as much as possible to our veterans. Again, we're still in the infancy stages. We're just coming up to our year anniversary of operationalizing. I finally got that word. Thank you very much. Operationalizing the CCC a year. We had 1 million calls handled at the end of December, projecting a 1.3 million calls this year. I'm really excited about this service, bringing our VA to the 21st century, providing this virtual care, and excited to see where this is going to go. So thank you for your support and
Thank
whatever.
you. Thank you.
Take care, everybody.
Thank you.
I know we're a little over. I don't necessarily have anything else on my agenda other than I just want to let you know that if you haven't heard, we're going to get some extra money before the end of the year per Gerard. So I've been talking to folks, and I'm kind of making a wish list of things to order. So I'm just going to order some bonus swag to have on hand because Peter's closet's getting kind of depleted over the pandemic. Um, so that's really my other big thing. Let me go around the room. Does anybody have anything they wanted to chat about or need assistance with, or something upcoming they wanted to share? The only other thing, this just happened right before we started. Peter Potter, our public affairs officer, we did a PACT Act yesterday. We hosted PACT Act town hall for Congressman Tonko and did a presentation and had some services around. Thank you to everybody who participated. Senator Gillibrand's office just reached out to him to see if we could do something like that in March. So we're gonna, once they sure up the whens and wheres, we'll probably send a mini group because it won't be as a place as spacious as Building 67. That's all I got. All right. Well, oh, actually, before I forget, I know I sent an email, but I want to thank everybody for all your hard work. If you missed a message, because I know we get a lot of emails, Gerard forwarded, or actually Peter forwarded the Q1 uniques, and we are the only hospital in the 11 medical centers with a positive growth rate for Q1. And if you could look at that, a lot of them are pretty in the negative. They're dark red. So thank you for all you're doing. I appreciate it. That's all I got. Yes, Daryl. Did you want to compliment me?
Negative, Sean.
All right.
I just wanted to apologize to the group. Sorry I was late. I was in another meeting with the team for behavioral health, and so that's why I came in late.
I did record Mr. Wilkinson's presentation, so if you did join a little later, it's all in there.
Okay.
I had invited him because I realized, I think it was like December, someone was talking about the tele-urgent care, and I didn't know about it. And I realized that a fair number of veterans we meet in outreach are connected to the system. So it's just another tool for us, maybe if they're falling out of primary care, or they haven't been in primary care in 5 years, another carrot to dangle to get them connected back to the hospital. All right. Thank you, everybody. Sorry for keeping you a little over. Have a good rest of your day.
You too, Sean. Thanks.
Thanks, Sean.
Thanks, Sean. Bye.